Be moving to the next section, and it's going to be a symposium. So this is the first EMSON symposium we'll be having, and the topic for this symposium is emerging biomarkers in diabetes mellitus, challenges and opportunities in screening for diabetes in a low resource setting. And to introduce the speaker for this occasion, I'll be calling Professor T.A. Samuel to please come to the high table mark alongside Professor Idowu Akonde. Sir, thank you so much. To co-chair this section is Dr. J.O. Eda. Please, ma, kindly come to the high table, ma. And to co-chair is Dr. Umori. I don't know whether he's here. Dr. Umori. Okay, in his absence, we'll call on Dr. Okay, he's here. Thank you. Kindly come to the podium, sir.
Good afternoon, all. I welcome you all to this first symposium of this year's EMSON's AGM. And it will be on one of our sub-themes, emerging biomarkers in diabetes mellitus, challenges and opportunities in screening in low resource settings. So, welcome the first speaker, Professor T.A. Samuel, to have our first talk. This symposium is for 40 minutes and we will try to keep to time here. So 20 minutes.
Distinguished colleagues, I greet you. Good afternoon. And it's been a wonderful meeting time since yesterday, actually since 2 days ago. And I am sure we will all leave this 46th EMSON meeting even better informed. My name is Aderonke Samuel, and the title is Old and Emerging Biomarkers in Diabetes Mellitus. Well, I'm speaking with those who, while sleeping, can speak about diabetes. And so I'm not going to go into too much details, but the prevalence has become a major challenge globally. And it is becoming imperative that early diagnosis and monitoring is critical for preventing complication. We just heard about complication in kidney diseases. And so, biomarkers provide objective measurements of disease presence, of disease severity, and prognosis. There are those biomarkers we know, and those are termed the traditional biomarkers. And we all know they have their limitations. And therefore, the quest, especially for those of us on the bench, is looking for new, novel, specific, sensitive biomarkers so that we can begin to talk about precision and personalized medicine. Well, the pathophysiological basis of biomarker lies in the fact that disease disrupts normal biological homeostasis. And so, there will definitely be measurable alterations in one, glucose regulation, insulin resistance and beta cell dysfunction, inflammation, oxidative stress, and endothelial dysfunction. And I'm glad that this morning, earlier on, we heard about the fact that even yesterday, that diabetes is no longer one single disease. In fact, the right word to use these days is that it is a metabolic syndrome, meaning it is a conglomerate of so many other things coming together. The old and the traditional biomarkers, of course, which we all know, the fasting plasma glucose, the pro is that it's simple, it's cheap, but it's a single time point. It's affected by stress, illness, and food intake. and you will bear with me. Nigeria is one stressor in itself. The oral glucose tolerance test. This is a 2-hour plasma glucose, and it is sensitive for impaired glucose tolerance. That's the plus for it. For the minus, it is time consuming. The reproducibility is poor. And of course, we have also heard all through today how inconvenient it could be for the patient. The glycated hemoglobin. It's convenient. It's not fasting dependent. It could be altered by anemia, hemoglobinopathy, and pregnancy. The fructosamine and glycated albumin. This reflects glycemia over 2 to 3 weeks. It's useful when HbA1c is unreliable, but it can be altered by albumin level or liver disease, which we just heard could be a comorbidity in diabetes. The C-peptide is an indicator of endogenous insulin secretion. And this can differentiate type 1 and type 2, but it's a bit expensive. It's not widely available in routine practice. Now, what are the limitations of these traditional biomarkers? Like I have said, they do not detect early beta cell dysfunction, and they do not reflect other underlying pathophysiological conditions and changes like oxidative stress, inflammation, but most importantly, what we now preach, genetics and genomics. It doesn't just talk about who you are. Everything we've heard today, it is been brought in from somewhere. In fact, we heard that some tests were carried out in international community and then given to us. This makes the traditional biomarkers a bit limited in predicting, and the power for being able to predict complication is a bit reduced. Now, we now have emerging biomarkers. And basically, what are they supposed to do? Those are to measure the beta cell function and the stress markers. They're to measure the pro-insulin and the pro-insulin to insulin ratio for early beta cell dysfunction. And a good example is the uncoupling protein 2. This modulates insulin secretion. Also, islet amyloid polypeptide, IAPP. It's an amylin analog. And there are actually drugs already in the market that mimics amylin analog. And they used to, these are drugs in diabetic therapy. But what do? They are markers of beta cell stress. They do not wait until things have turned upside down before you begin to be able to know that if you measure these biomarkers, you will get at least an idea of the situation of your patient. The second set are the insulin resistance markers, the adipokines, the adiponectins, leptin, resistins. We all know that low adiponectin is strongly linked to type 2 diabetes risk. The free fatty acids is also implicated in elevating insulin resistance. There are also inflammatory markers, and these days diabetes has been linked nicely and well established to a lot of inflammatory reactions. And you have the eye-sensitive C-reactive protein. This is a systemic inflammatory predictor of type 2 diabetes mellitus. Incidentally, we used to think interleukins were linked to cancers, but now we know interleukins are linked also to insulin resistance. So if you can measure IL-6, IL-1 beta, you could begin to. And these are new and they're emerging. The tumor necrosis factor alpha also impairs the insulin signaling. There are more oxidative stress markers. 8-OHDG, 8-hydroxydeoxyguanosine. This is a DNA oxidative damage biomarker. And it is important because, see, sometimes, like I said, we need to begin to look at the genetics and the genomics of what is happening. A lot of times, the environment, the real disease, but there is also that huge place that is reserved for the genetics and the genomics of who you are. There is also AOPP, advanced oxidative protein products. These are essential, and they are markers of oxidative stress and inflammation. Endothelial dysfunction and vascular biomarkers, microRNAs. These regulate beta cell survival and insulin signaling. Sometimes it is not that insulin is not produced. It could be the signal. It could be the receptor. It could be the cascade effect. And these are the deeper things that we need to see. Because you won't give a drug and you are wondering, well, why is it not going down? Why is this patient getting better? It might be because the marker you had used might not actually identify what the issue is. It could be a deeper issue. There is the endothelin 1, VCAM1, and ICAM1. And these would measure the vascular dysfunction. They are predictors of diabetic complications. The genetic and the epigenetic markers. We carry a lot of SNPs. As a matter of fact, it is said that every day there are about 1,000 SNPs. But because you and I are in good health, those can be corrected without us knowing. But a lot of times, those single nucleotide polymorphism could actually derail our health patterns. And so, the epigenetic changes in our DNA could also be predictive markers of insulin or insulin complications. Finally, the metabolic-based biomarkers. These will measure the protein at the end of the day. And we have the BCAA, and they measure the branch-chain amino acids. And they also are markers of insulin resistance. There are specific lipidomic signatures that are also linked to DNA, to diabetes mellitus risk. Now, what is the clinical implication of going to these new and novel biomarkers? The world is headed to precision or personalized healthcare, and we cannot afford to be sitting behind. And so, the clinical implication is that we should join everyone else to go where they're going. To them, yesterday I heard about individualized treatments. But trust me, after individualized treatment, there is precision or personalized treatment as well. And we cannot do that if you are not versed in the new emerging biomarkers. It can also be that we can predict risk. These days, people go to clinics to be able to predict their risk and to ask that simple question: am I part of those whose genome is saying in 5 years, this will be my status? Angelina Joe, whatever her name is. Thank you. The only thing she did was that she knew that all the women surrounding her mother died from cancer. She didn't have cancer, but she went and did BRCA1 and 2. And she was able to predict nicely that she could be part of that statistics. And she did a very beautiful thing. She removed the 2 breasts and she removed her womb. As of today, she's still fine. Now, years down the line, we do not know what the issue would be. But she was able to know that in years to come, you will follow your mother. Your mother died at 46, a sister at 48, your cousin at 45, all of them between 45 and 48. And she knew she was already 42. She was moving closer. She didn't want the clock to tick by her. She went, did the test. Of course, we understand that things aren't that easy here. But honestly, we will get there. And we can begin to monitor complications. If you already have a particular disease, will there be a morbidity of another disease? So those are the clinical implications of these new and novel biomarkers. And like I said, it leads us to precision medicine so that we're not just toying in the dark. Precise, and we're doing personalized so that we can properly diagnose and begin treatment strategies of the individual characteristics of each patient, such as looking at the genetics, looking at the environmental, the lifestyle, and the biomarkers, so that we stop using one size fits all. Now, what are the key features of these new biomarkers? They will then be patient-centered, predictive, preventive, personalized, and participatory. Because, you will be the one to make a request like that woman made a request. I have seen my family go this. Can I know what my status is? Of course, there are examples. This is small in cancer oncology, but we also have in diabetes mellitus. I have this example, an obese man, family history, DM, borderline, FPG, HbA1c. And the question is, which biomarker could help predict the progression? Now, for a recap, the man is 45, he has risk factors, obesity, family history of DM, borderline, impaired fasting glucose, as we've seen, HbA1c already elevated, pre-diabetic. So the man is not diabetic yet, but trust me, from what we see here, is at a high risk of progression. And so what biomarker could help predict progression to overt diabetes? And any of these 5 will do just that if he has enough money to do it. We know that HbA1c would be less useful. He's on the borderline. FPG is already being measured, and so that is limited in its predictive power. And so, for that patient, low adiponectin, elevated proinsulin to insulin ratio, raised HSCRP or metabolomic changes, BCAA, could be strong indicator of progression to type 2 diabetes. That is the kind of way we need to go, looking at the new and the emerging biomarkers. Well, you might say, is this possible? I'm glad to say that it is possible. In the University of Lagos, it is possible. The university runs a Center for Genomics of Non-Communicable Diseases and Personalized Healthcare. And I'm glad to say that we have been opportuned to run a few NIH grants, a few TED Fund grants, a few national, I refuse to call it local grants, to enhance what we do as a center. And in that center, we are always looking for new and emerging biomarkers. We do collaborative research. And like I put here, the thematic area, the metabolic disease thematic lead, is no other person than Professor Fasamadi. Now, what are the challenges and opportunities in screening for diabetes mellitus in low-resource setting? There will be limited infrastructure and resources, no doubt about that. It is limited. Cost is high. Those are the challenges. There is human resource constraints, and that was why we got an NIH grant to be able to train the trainers and to train ourselves and to write up a curriculum that every year we will begin to train people in how to look for these emerging biomarkers. There is low awareness, and all of us, I jokingly told somebody that Dr. Mrs. Fasamade gave us endocrine on friendly food this afternoon. Today was better. Yesterday was worse. We had 2 pieces of dough in our tea break. And I said, while Professor Oborile was alive, we would never dare do that. There are competing health priorities. Somebody said we should speak to our government. Trust me, non-communicable diseases is not in the front burner. But you and I need to do our bit to make sure that it is in the front burner. Because we now know that even the communicable diseases, people succumb to them because they have underlying non-communicable diseases. See the number of people that died during COVID. Quite a lot was because of obesity, diabetes, cancer, and all sorts of things. So we must begin to speak and advocate for ourselves. Geographical and logistical barriers, that is... some people are in Lagos, but trust me, they are not in Lagos. When they tell you where they live, you will ask, sorry, where is that? And that becomes an issue. So for such a person, even to come to General Hospital Ikeja becomes an issue. Not talk of coming all the way to Luth. The man must then sleep over in Luth for him to be able to appear in Luth the next day. Now, what are the opportunities? It's used for point of care testing. We can shift and begin to use even community efforts. And I saw this a lot when I sat as chair of a state's board of primary health care. It was community, all those places that you park your car and you walk, or you take Okada. There were community people that were doing things for them that you would open your mouth. So we could shift that, especially to those unreached people. We can begin to do risk score screening using questionnaire. And we can integrate diabetes into other health programs. Well, there could be mobile health and digital innovation. I know that there is someone who runs a cancer clinic, and she has something she's done. You could put all your whatever you have that is wrong with you on your phone, and it is transmitted to her. And she's in Lagos. It's transmitted to her, and she's able to call you or follow up with you or whatever it is. I know that is also possible. But most importantly, we need policy and public health initiatives. We must begin to speak for ourselves. Finally, preventive lifestyle intervention. I pray that we get there. Some people were telling me you need to do 10,000 steps per day. And I said, out of how many hours in a day? But trust me, preventive lifestyle intervention would get us to at least not have a complicated DM issue. My summary is that screening for diabetes in low resource settings faces barriers such as limited infrastructure, cost, and low awareness. But innovative, low-cost, and community-based approach using POCT, choose integration with existing programs, and ML offers practical opportunities to expand early detection and to reduce complication. Distinguished colleagues, I want to thank you for this opportunity. I don't take it for granted. I thank you most sincerely. Thank you very much.
Thank you so much, Professor Samuel, for this wonderful presentation. We'll call on Professor Akande to give us the second one. Sorry, sir.
Thank you so much, Professor Samuel.
Bonale, please. You want to give a citation? We don't have time. Okay. Okay. Okay, so. Sorry.
Thank you so much, Professor Samuel, for that very stimulating lecture. And to move further in this presentation, we have a guest speaker in our midst, who is Professor Idowu S. Akande. He's a professor of biochemistry, College of Medicine, University of Lagos, Idiaraba, Lagos. So I'm going to be giving an abridged citation about him. Professor Akande is a biochemistry chemist and has experience, training, expertise, and motivation necessary to successfully carry out research projects. He had his undergraduate degree in biochemistry, graduated from University of Ibadan in 1987, masters in zoology parasitology in 1997 from Bayo University, Kano, and a PhD in biochemistry from University of Ibadan in 2010. His research includes nutrition in health and disease, novel drug development from plant sources, and toxicology. And he has been a principal investigator in many studies. Professor Akande is a member of many academic and professional bodies and has published extensively in public health issues, natural products, toxicology, and medicinal plants. He has research collaborators within and outside Nigeria. They include quite a number of professors. He delivered the 11th inaugural lecture 2024-2025 section of University of Lagos on the 23rd of April this year, titled Use, Misuse, and Unused Natural Gift of Medicinal Plants, Natural and Synthetic Products in Tropical Medicine. He has served as the HOD Biochemistry, College of Medicine, University of Lagos from 2010 to 2020. Please join me as we warmly welcome Professor Idowu Akande to take us further in this symposium. Thank you, sir.
I want to stand on the existing protocol, and I want to also thank the association, Endocrine and Metabolism Society of Nigeria for this very rare privilege to address us in this symposium. I also want to acknowledge the presence of my bosses in the past and even presently, Professor Mrs. Oimagbagwiola was my head of department, biochemistry department, and also have a good friend and a boss too, Professor Fasamade is here, and the host of other, including Professor Samuel. Well, Professor Samuel has made my job a lot easier by what she has presented, because basically I've been asked to present on the same topic, emerging biomarkers in diabetes mellitus, challenges and opportunities in screening for diabetes mellitus in low resource settings. And I want to say here clearly that what we are looking at is something that is very, very important, especially for those of us who are here and also for the people that we are reaching out even to. I'll be guided by this outline. Well, there is nobody here I want to believe who will not be able to really explain even better what diabetes mellitus is all about. But the point is, it is a rising global health issue. Professor Fasamade gave us epidemiological data about the current prevalence of diabetes mellitus. And so in this short symposium, I'll be talking about biomarkers in diabetes mellitus, the challenges in the low resource settings and what are low resource settings, and then the possible solution. Now, Professor Samuel, like I said, has made my work a lot easier. But let me just add a little flavor. And may I also say that because I discovered that we prepare similarly, almost something similar, I had to tinker with my presentation. So you will see some side digressions which I believe are thought-provoking, not just on the screening or diagnosis, but possible intervention or treatment in cases of diabetes mellitus, whether type 1, type 2, or gestational. So we have one, metabolic biomarkers that are indicators of metabolic processes, and they include glycated hemoglobin, which measure average blood glucose level over between 2 and 3 months. Then we have what is normally called fasting blood glucose, which measure current blood glucose level, and then the glycated albumin, which we have been talking about since, which reflect the short-term glycemic control. Now, we also have immunological biomarkers. These are general terms, but they embrace so much. Now, we have indicator of immune responses, including autoantibodies. There are some autoimmune diseases that are responsible for this very metabolic syndrome we are talking about. And these include related to type 1 diabetes, and they include cytokines and the chemokines that are involved in inflammatory reaction and immune responses. We also have what we call microbial biomarkers. Here we have indicators of gut microbiota. These are microorganisms that are found. Their composition include Prevotella, Streptococcus, Bacteroides, which are linked to latent tuberculosis infection that can be a co-infection even in diabetes mellitus patients. Then we have genetic biomarkers too, which include indicator of genetic predisposition, including STAT1, EV3, and they are related to diabetes mellitus. In the diabetes mellitus tuberculosis comorbidity. Now, what are the challenges in low resource settings? Because once again, I have to be referring to her. She has spoken about them, but let me still mention them. One, we have limited access to healthcare. Because when we talk about low resource setting, we should also define that. Really, we have third world country, we have a medium low income country, and then we have those ones that are advanced. So when we talk about low resource setting, it's very relative. For Nigeria, for instance, now we are in the third world, and we are referred to as a low-income setting. So Nigeria, in a way, even though we still have some resources that are very vast in nature, but not being harnessed and utilized. So it can also refer to Nigeria, but it can also refer to poorer countries. When you talk about Central African Republic, Guinea, and all that, they cannot be comparable to Nigeria in terms of resources and all that. But low-income resource setting, they include both the Nigeria that is a bit vast in the resources and some of those other places. So we have limited access to healthcare. There is trouble accessing healthcare facility and diagnostic tools. And then the cost constraint is another challenge. That is, the cost of diagnostic tests and treatment, they are very, and then lack of standardization. Many a time, precision, like she said, but besides precision, we also talk about accuracy. Or a challenge sometimes. And then we also talk about limited awareness. Low awareness about diabetes mellitus and its complication among healthcare providers and patients. Now, even though those are the various challenges, but they also present and provide opportunity and solutions. I will run through this because Professor Samuel spoke about them. What are the opportunities in the midst of these challenges? We have the use of point-of-care diagnostic tools that are very important, that are readily available and not too expensive. And so we can also improve on that by creating low-cost, portable diagnostic tools for diabetes mellitus screening and diagnosis. And that becomes more imperative and also feasible, especially in this era of artificial intelligence, machine learning, and big data. We don't need to depend on using AccuCheck and all that now. I think there are people that are our students, that are our trainees, that actually are versed now in the use of some of these tools. And therefore, we can actually, they can manufacture, they can create opportunity for the point-of-care diagnostics tool. And also the use of multi-omics approaches that combine genomics, proteomics, and metabolomics to find new biomarkers. In the days we live now, the use of bioinformatics is very important, and also what we call in silico study in what we call molecular docking, where we make use of ligands and then to identify protein. And then without even doing wet laboratory work, we can target some protein that are related to metabolic syndrome and related disorder or diseases. And then we can use some of these bioinformatic tools, artificial intelligence, and also all the other tools that are related to come up with possible to identify new biomarkers. And then also we can make use of international collaborations where we have global partners which help us to standardize biomarker measurement and interpretation, and also capacity building. Just like we are here now, we are building capacity. We are being trained, and as trainers, we go back to do training for others. So, capacity building, training healthcare work providers and patients on diabetes mellitus management and prevention. Now, what are the emerging biomarkers? We've talked about the traditional old biomarkers, but there are emerging ones now that are simple. Even the low-income resource setting, they can easily be done. One is uric acid to albumin ratio. This can easily be done. And if it is the ratio high, there is a range. If it is high, it can be a predictive marker for all cause and cardiovascular death in diabetic patients. Homocysteine is an amino acid that is found in the blood. When it is elevated too, that can be used as a biomarker. It is linked to nerve conduction velocity and is related to diabetic kidney disease. Then glycated albumin, she has spoken about that. And then the KCNQ1 gene polymorphism. I need to talk a little about this. This is potassium voltage gated ion channel. It's a biochemical and physiological gene that is located and can be used to actually predict susceptibility to gestational diabetes mellitus, especially in the first two trimester for the pregnant people. So this is very, very important. If it's also elevated, it can be a predictor or a biomarker for. Now, in concluding, we can say that new biomarkers offer promising chances for early detection, diagnosis and management of diabetes mellitus in low resource setting, and to overcome challenges and capitalize on opportunities. We require a multifaceted approaches. These include developing low-cost diagnostic tools, standardizing biomarker, measurement, and building capacity. And by working together, we can enhance diabetes mellitus care and outcome in low resource setting. As I want to round up, like I've said, I have to think out with the presentation so that it will not be a run of the mill or just repeating what she has said. Let me just give you one or two. Now, I wouldn't know those of us who are here, especially those of us that are medics. In the various interventions, there is one that is currently undergoing scrutiny, even in Nigeria now, and that is the use of maggot therapy. How many of us have heard about that? It's being used. All right. Okay. So that's one, maggot therapy. We can improve on that. Then we can also incorporate what we call zinc iontophoresis. Have we heard of that before? Zinc iontophoresis. Yes. That's also can be used. And then the use of medicinal plants and all that in the management, such as berberine, gymnema, and then cinnamon, which are common things that are variously seen. And then the last thing I want to say here is, in one of the presentations this morning, somebody mentioned the current prevalence of comorbidity of hypertension and diabetes, and that is about 70%. Now it has been observed, and I also want to learn. Many a times you have some people, they have diabetes mellitus, but they don't have hypertension. There's sometimes people that start with hypertension, most times, maybe more than 80%, they end up having diabetes. What is the problem? So it's a question I want us to give me. Now, the point is that it's likely that many a time, the drugs that are employed in the treatment of the hypertension, they eventually, yes. Again? Yes, can lead to that. So we need to look at that correlation and see what we can do. Now is this one is a personal experience I had. I visited somebody in the hospital recently. He was having this diabetic foot ulcer, and eventually I think the complication set in so much he had to be amputated. And while he was talking to me, because I'm also a pastor, he said that day was operated on in Nasutia 7 other patients. In fact, it was just like a market. They were going in, coming out, either the foot being amputated or the leg. Now, we can see that there is a rise in this complication to diabetes and then this issue of amputation. Now, we are here to put it together, and I believe we can be even of help. Thank you, and God bless you for listening.
Thank you very much, Professor Akande, for your lecture. We appreciate it. Unfortunately, we don't have time, so we won't be able to take any questions. Okay? So thank you so much. I know that there are several biomarkers. Research is ongoing, even to identify the risks for peripheral neuropathy in patients with diabetes. So I'm sure before long we'll have so many biomarkers that will help in predicting risks for diseases and even complications. So thank you so much for your attention and for supporting us in this symposium. So please let's give our speakers another round of applause. So I will invite Professor Oloko, the EMSON president, to give the speakers their thanks.
Good afternoon, distinguished senior colleagues and colleagues. To present this award, kindly allow me to invite Professor Oshinubi to come and do this presentation. Please put your hands together for Professor Oshinubi. Thank you, sir.
Thank you, President. On behalf of the Endocrine and Metabolism Society of Nigeria, I hereby present this plaque to Professor Idowu Akonde as the guest speaker of the 46th Annual General Meeting and Scientific Conference. Congratulations, sir.
I need to do this so that I won't receive query after leaving here. This is my Dean of Dean, the AAA, Professor Shinobi. I sure acknowledge presence and I thank him immensely too for being here with us and also for the opportunity I have. This is my Dean of Dean from the University of Lagos. Thank you.
Thank you.
Thank you very much. Well, we are not done yet, I know. You see that my pick was quite wisely guided. And thank you, Professor Oshinubi, for doing a great job. To present the next plaque to Professor Aderonke Samuel, allow me the privilege and honor of inviting Professor Mababiola to please come forward and do this for me. So you see, thank you, ma. I was led by the Spirit.
On behalf of Endocrine and Metabolism Society of Nigeria, I present this plaque to you, Professor Aderonke Samuel, in appreciation of your role as faculty speaker at the 46th Annual General Meeting and Scientific Conference. Yes. Congratulations, man. I think I was embarrassed.
No, ma.
Because let me remind everybody. I joined this society in 1980. And after some time, I was asked to bring a mentee or mentees. While I was the VP to Professor Owofoweri. So I invited her. She was doing her PhD under me then. And I thank God that she remained steadfast in the society. Even though most of the time, usually we have our annual conferences around September, and I'm always not around. It's only few times that I'm in Nigeria that will come. Luckily, this year, I'm here. Last year, I wasn't around either. So, thank God for the growth of the society. So many people were included, and I'm seeing many new faces. We praise God for the growth of the society.
Thank you. Thank you so much. So let's put our hands together for them. We respect very dearly where we have the opportunity of having a mentor around. The mentee must do what is expected by paying homage. And that has happened this morning. Thank you so very much. Thank you.
Thank you, sir. Thank you, Professor Loco. Thank you, Professor Akonde and Professor Samuel. We are really grateful.